Hey Dan, hi Melody. Morning.
Hello, morning.
You're a bit slack there, Jane, mate. We thought you're a bit slack there, mate. We've been waiting for ages for you to come in.
I was just on with DFAT on another issue. Yeah, meetings. You know what it's like.
I thought you had a clone. Didn't you have a clone? Haven't you got a clone?
Well, I wish sometimes. What's going on? Yeah. Hey, Suzanne, Sudhir, Ceci.
Hi.
Hi, Sudhir. What time is it with you, Sudhir?
It's just at 2 a.m. and there's
Oh.
a major thunderstorm coming.
Oh my gosh.
It looks almost like a flooding thunderstorm.
Oh no.
Yeah.
We had one this morning. A bit of a thunderstorm came through.
Hi, Moses. How are you?
Buladen, I'm all good, thank you.
Oh, good.
Hey, we can only see your the bottom of your face there. You might have to adjust your camera. We can only see your smile. That's it.
Moses, so you know Melody. Melody, she works with Paul Monis, of course. So Melody works with Paul.
Yes.
Okay.
So Paul's been talking to Moses a bit as well.
Okay. Bula Melody.
Will we see Katie as well?
Yeah, he should be coming online soon.
Great. Melody, Katie gave us a tour of her lab. It's really good.
Oh, that's
Yeah.
good.
They haven't got the molecular biology, but they've got all the other bits, the vortex and the centrifuge and all the other sort of things. So she did a very good job holding the camera and showing us around.
Why she need recording?
I've tried to be in touch with PNG today as well, Dan, to get the health department to come, so we'll see how we go.
Great.
And Samoa Water, so we should get a crowd.
You're okay to share the presentation, Dean?
Yep.
Cool.
I'll make you a co-presenter just in case things drop out.
Oh yeah, I'll pin all the panelists when it's time for your Q&A panel.
Okay.
I've left quarantine now, Dean. So I've told everyone in Alice to lock themselves away. There's a Sydney person on the loose and a Sydney person on the loose. So
Oh, we'll be all out of lockdown soon. That'll be good.
there it goes. Yeah.
We might all be able to travel soon too.
Until the ICU bed fill up again, then I'll be back in again, I think. Let's see what happens. I'm a bit skeptical about that, but we'll see what happens.
Yeah, we'll see. Yeah, I'm not booking the flights yet.
They've been in a lockdown in Japan and Singapore and all, for months, haven't they? They sort of, when the beds get full, they go back into lockdown again. So
Yeah.
I need to come to Manila. We're up to like 500 odd days here.
of lockdown, really?
Yeah.
Christ.
That's Emma Veve, our DDG, and then Emma, this is
Hey, Maria.
part of our panel.
Right. Okay. Sorry, couldn't help joining the conversation.
Yeah, no worries. Glad to have you.
What's the vaccination rate and which vaccines are being used in Manila? Is it,
They're up to about 20% at the moment.
The presentation there.
Yep.
Right. Okay, we'll get underway in just a second. So if you could please turn your microphone off if you're not presenting. We'll get a bit of feedback and a bit of noise. So if you could just turn that off, that'd be great. We use the chat function. So if you want to jump in, have a chat, that'd be great. And also raise your hand. So you find those buttons in your controls there, probably at the bottom of your screen. So, yeah, and please jump onto the chat and say hello and just introduce yourself. And if you could let us know if you're a participant today, where you're from. And as Maria said earlier, you can rename yourself, which helps as well. If you go to your face there, your log on, there should be 3 buttons, 3 dots next to it, and you can rename yourself. So if you're a participant, if you could just let us know where you're from, that's really helpful. It's a bit cryptic sometimes with people login names. And we'll certainly have, today's a real workshop webinar, and we'll have some panel discussion. So a lot of time this morning for some questions. So yeah, so please keep track of your questions, drop them in the chat, we'll monitor that, and then please jump into the panel Q&A. Okay, I think we might make a start. I'll drive the presentation this morning. Okay, so welcome to the latest in our Pacific WASH webinars. I think this is webinar, I haven't counted it, maybe number 8 or 9. So yeah, it's great to be able to continue this series. And today we're really grateful to have some presenters from all around the world, so experts in their field. And today's topics are wastewater surveillance. And there's been a lot of discussion in our talks to utilities and health departments. A lot of interest in this topic, so we thought it'd be great. Really appreciate the team that's come together today to talk about wastewater surveillance and its use in the Pacific for COVID response, and not only COVID response, but how we can potentially use that in the world beyond COVID. So this morning, I'll hand over very shortly to Emma Veve, the Deputy Director General of the Pacific Department of the ADB, and Lucia, CEO of the PWWA. And then we've got our 4 presenters. So we've got, we'll start off with Rachel Poon. Rachel is from the Victorian Department of Health. Then Tiffany Chen from Sydney Water Corporation. Then we've got Melody Lau from SA Water. And Sude Pillay will bring us home. And Sude is from the Water Research, WRC in South Africa. And then Marlene will facilitate us. Marlene's from the Water Research Australia. Marlene will help us with our panel discussion. So that's our agenda for this morning. So without further ado, I'll hand over to Emma Veve to take us to give some opening remarks. Thanks, Emma.
Thanks so much, Dean. And good morning, everyone. Good afternoon, evening, if you're coming from other time zones further away. And welcome to what I can confirm is actually indeed the 9th webinar in the Pacific WASH seminar series. This series has been running for several months now and does form part of ADB's WASH support to the Pacific Island countries during the COVID pandemic. The seminar series has offered a wide range of topics so far, from things like chlorination to gender mainstreaming. But today we're exploring what has been a highly requested topic on wastewater surveillance for COVID-19, how it can be helpful now, and also how, as Dean said, it can be helpful into the future. The webinar topics particularly relevant to our Pacific colleagues in Fiji and PNG who are suffering from a COVID outbreak. But our team has assembled some of the world's leaders on this topic to ensure that the webinar is helpful to all of our Pacific member countries' public health responses at all stages of dealing with COVID-19 and beyond. Like all our webinars, the information provided here intends to start a conversation. The Pacific WASH TA provides demand-driven support to crucial WASH stakeholders in building resilience to the pandemic. So we encourage you to really reach out to us during and after this event for more information and for specific support you may need. In closing, let me thank you for joining today, and I encourage you to leave comments during the webinar to know what you'd like us to discuss in the future. So please enjoy, and we hope to see you at the next event too. I'll hand back to you, Dean. Thank you.
Great, thanks for your opening, Emma. Lucia, are you with us this morning?
Yes, Dean. Thank
Yeah,
you.
good morning.
I'm sorry, I got a bit disoriented with the changing times. It registers to start at 2 o'clock on my on my computer, but I just wanted to check at 1 o'clock, and just in case, because of our country has been playing around with the times. Anyway, with daylight saving. Anyway, good morning, and talofa, and welcome everyone to this webinar series. And this is our 8th series so far. But firstly, let me say we are, again, very grateful and fortunate for this collaboration with ADB in bringing everyone together of our member utilities to learn from industry and sector experts and from each other through sharing knowledge and expertise in the field and how others are coping with WASH issues. And today, as Dean has said, we have a very interesting technical and topical webinar, highly relevant to the times we are in at the moment with COVID-19. And the first we have touched on in terms of wastewater surveillance. We have an excellent team of speakers and panelists for this discussion, and I wish to also welcome and thank them for the speakers and the panel of experts for availing their time for this webinar. And thank you also to our member utilities who have chosen to participate in this important series. I really am looking forward to hearing from the speakers and the panel members today on this important topic, and also to everyone's interaction and participation. So without further delay, I'll hand it over back to Dean to continue with the rest of our webinar. Thank you.
Great, thanks a lot, Lucia. Okay, so we'll get into our presentation. But before we start, I'd really like to thank our presenters that have taken what little spare time they've got in their busy lives to join us today and prepare the presentations we've got. And particularly Sudhir, who's in South Africa, and he said it's 2 a.m. his time. So real commitment to the cause in the Pacific. So thanks a lot again for joining us. Okay. Right, so I'd like to introduce Rachel Poon, Principal Scientist from the Department of Health in Victoria. Morning, Rachel.
Great, many thanks, Dean, and thank you for the opportunity to present to you all today. We're very happy to field questions and happy to talk through any discussion points down later on as well. So I'll just provide a little bit of context. Right, Dean, just going back to that first slide, I'll just introduce where we're from. Victoria is that little wedge, that red wedge, that triangular shape in Australia. And I'm from the health department there. So we previously never had any wastewater surveillance programs in place. So we stood up this program very quickly last year in response to the COVID-19 pandemic. So moving to the next slide, I'll talk to you about, I guess, the primary aims and objectives of the wastewater surveillance for SARS-CoV-2. And really it's to provide early warning and to enable early case detection of the virus in the community. And Victoria has been in a low case setting, so we haven't had many cases of COVID-19 in the community. However, we're now in a high case setting where we're getting, 1,400, 1,100 cases a day. So that's the scenario we're at the moment. And then, sorry, still on the previous slide, but we have two other aims, and one is to also contribute to global best practice and learnings, and also communication of unexpected detections for behaviour change and to get people in the community to go and get tested. But in terms of, so yeah, they're the three aims, and some of the comms that we have been putting out is through social media, and that example on the right is one of the comms images that we put out on I think Facebook posts. So looking at the next slide, I really want to highlight that surveillance for our COVID-19 response is a joint kind of clinical testing as well as wastewater testing approach. So clinical testing requires an individual to go get tested, and it usually requires behaviour change for that individual who's symptomatic to go and get tested. Whereas wastewater surveillance, we can do that at different levels. So we can look at whole region, we can look at a specific facility, but it's representative of the people in that catchment. So it's a population sample, and it includes people that are both symptomatic and also asymptomatic. And what we have seen through our surveillance program is that we have got detections early when people are shedding the virus before they have symptoms. So that early warning has really been quite effective through this program. So looking at the next slide, this is just a snapshot of the program we have in Victoria. Each of these little dots on the map, so the teardrop shapes, you know, the green tick is an expected detection. The green tick is a non-detection, so that's a good thing. The little cross is an area where we had sampled, but we're not sampling at the moment. And then the red dots or the exclamation marks are where we have expected detection, so where we know that there's cases of COVID-19 in that particular part of the catchment. And I guess the context is that we have been in lockdown for a significant portion of the last year and a half. So that also helps with us analysing results as well. So the program is very much adaptive, and we are able to switch sites on and off depending on the risk. And looking at this slide now on the wastewater surveillance process flow, samples are collected, and that's either at a wastewater treatment plant, or it could be within the sewer network, or it could also be at a specific facility. There's two different types of samples that we collect. Wastewater samples could be a grab or a composite sample, or it could be this innovative type of sample called a pathogen sampler, and it's a 3D printed sampling device that's fairly cheap and easy to deploy. So this is one of the key innovations that have come out from the McCarthy lab at Monash University. The samples are analysed at one of two labs and confirmed through an additional lab. A subset of results are confirmed if they're weak detections or a single gene detection. And then we analyse all of the results using the catchments to check if there's any confirmed cases in those catchments. And then we then determine if it's a expected or an unexpected detection. And if it's an unexpected detection, then we take further public health action. So moving on to the next slide, I'll just talk through the low case setting. So wastewater surveillance in the low case setting, when we didn't have community transmission and most of the risk from COVID-19 entering the community was through hotel quarantine. So you can see here that we've got mostly the green ticks and the crosses, which mean that we have mostly non-detects throughout regional Victoria, and also in the middle here is the network catchments within metropolitan Melbourne, and we have a couple of sites with the exclamation mark, which is the expected detections, and they're generally where there's known cases or our hotel quarantine site. So that's the low case setting, and we were able to, I guess, in that low case setting, have some really nice case studies where we did have early warning. And one of them has been a regional town called Shepparton. It has a population of about, I think, 37,000 people. This blue outline in the image on the left is the catchment. And then the blue dots in the catchment are exposure sites. So they're sites where we know that a case has gone to visit one of these sites and there's been a risk of transmission. So the scenario in Shepparton was that we had wastewater detections. They were unexpected detections. So we knew that there were no known cases that we were aware of for 10 days before a case was diagnosed. And we saw that the quantitative signal, so the strength of the detection was increasing, which likely meant that there was infectious cases in the community. So the wastewater surveillance result was able to provide the local public health unit with an early warning. So they stood up increased capacity to test locals in the region. And they also had some local communications for people to go get tested. As a result of some cases being diagnosed and the number of exposure sites, there was a regional lockdown of this area, which limited people movement. And then we followed up with intensive wastewater sampling within this catchment, but we also broke down this catchment into smaller sections to try and isolate where we were getting detections and non-detections. So if we move to the next slide. So we knew that there were known cases in one of these particular catchments. I think it's the one in purple. Sampling at these other green, orange and blue sections gave us an indication of if there were any additional cases in the other areas within Shepparton. And we also got detects in those other catchments, which indicated that there were additional cases. And then the Shepparton outbreak actually grew to quite a significant outbreak with quite a number of cases. So then we actually moved to do some additional targeted surveillance. So this was looking at some of the areas where there were exposure sites. So there were some aged care facilities. We sampled at about 9 different aged care facilities in Shepparton and the surrounding area. And we also sampled at some industry sites. So there was a significant food processing facility with a large number of workers that we also sampled at. And we continue to get non-detections from all of those sites. So there was a reassurance from those non-detections that there was no workers or cases on site at that particular time. So the map down the bottom shows the neighbouring catchments, and you can see that we sampled at quite a number of surrounding areas, and we had reassurance that we didn't have additional and we didn't have additional unexpected detections in those areas. So the outbreak was limited to that Shepparton area. So moving on to the next slide. We're now in a scenario where we have high caseloads and significant number of COVID-19 cases in the community, and significant, I guess, onward transmission in the community as well. And as you can see now with the current map, that there's a lot more expected detections, not only in metropolitan Melbourne, but also in regional Victoria. So we've changed our program and adapted the program to see where it's bringing highest value. So we're no longer sampling, and if you have a look at the map on the right, there's a lot more orange. So we're no longer doing intensive sampling in those catchments. We're really focusing our efforts in regional Victoria, where we've got those green dots to make sure that we don't have additional unexpected cases in those regional areas. And then if we move to the next slide, we're also looking at more targeted surveillance. So thinking through where we can prevent spread in high transmission risk and more vulnerable settings. So aged care facilities, prisons, schools, high-rise social housing, and industry, so processing facilities. So that's our focus at the moment. And then just to wrap up, I guess, the key learnings and also important considerations in thinking about standing up a program, regardless of, I guess, the low or high case setting, is really that the surveillance program can really be adapted to risk and the particular setting. So you can really design the program to where you think you'll get most value. So targeting the wastewater surveillance in areas where there's also actionable public health response. So you want to make sure that wherever you target your wastewater surveillance, you can actually do something to prevent the spread in that particular setting. And particularly for early warning, it's important to have, I guess, optimized sampling methods and also timely reporting of results. And this is probably something that Tiffany and the other presenters will probably go into as well. I haven't really spoken a lot about the passive samplers, but that really is a better method for sampling rather than grab or composite samples. And also it's important to think through the turnaround time from when a sample is taken to when the result is reported to the department, to your relevant health department. I know here in Victoria, we have same day reporting of results in Metro Melbourne or next day. And for regional samples, it's usually the following day. And that enables us to have that early detection and quick response to unexpected detections. And lastly, how results are communicated to the public too. translate to behaviour change. So that's something that we're continuing to evaluate and trying to optimise. So that's it from me for today. I just wanted to acknowledge our water utility partners and our research and lab partners, as well as all the people within the department that have contributed to this program. Thank you.
Excellent. Thanks, Rachel. I'm sure there'll be a lot of questions when we get to the panel discussion. So thanks a lot for that. I'll now hand over to Tiffany from Sydney Water, who will talk to us about the utility perspective on wastewater surveillance.
Thank you, Dean and Rachel. Very happy to be here, and thank you very much for having us to talk to you guys about this program. So I'll be talking to you today about the utility perspective, about how we set up a monitoring program, and talking a bit more in depth into the ideas of the more targeted sampling and catchment sampling, as mentioned by Rachel. Sydney Water is in New South Wales, and our equivalent health department is New South Wales Health. On to the next slide. So just to give a bit of context, Sydney Water is Australia's largest water utility. We cover a population of approximately 5 million people and have about 25,000 wastewater or sewage pipes. So I am talking to you from the perspective of quite a large utility program and how we set that up. We use, our labs are able to detect SARS-CoV-2 in quite small quantities, which is very important. So initially, when we began this program, we believed that we'd be able to detect one positive case in about 10,000 people. As we've developed the program and we've had more correlation of our results to the clinical testing, we believe it's closer to one case in 100,000 people. So it's very sensitive and a very reproducible method. We initially started in February of 2020 with the method development and validation, and began sampling about 50 samples per week, which was a mix of samples from our treatment plants and regional partners. Over time, as this program has gained more momentum and has become more important in how we manage COVID, we've been ramping up to currently we're doing, I think, about 200 samples per week, and we're working our way up to 350 samples per week. Not all of those are samples from Sydney Water's area of operations. This includes our regional partners. On to the next slide, please. So the sampling process is very similar to what Rachel has shown up previously. We have two types of sampling. We have our routine monitoring program, which in the case we sample about 65 sites weekly within the Greater Sydney region, and that can scale up or scale down at the request of New South Wales Health, depending on what information they're trying to determine and whether or not they wish to prioritise samples coming from the regional areas or samples within the Greater Sydney area. We also do reactive sampling, which comes at the request of New South Wales Health. So in that case, they will send us a request to look at a particular area, and we will do a desktop analysis and work back and forth with New South Wales Health to select suitable network sites. We'll then sample, and the lab results will be sent to New South Wales Health, and in parallel to that, we'll also map the catchment of interest, determine the population that's within that catchment and the suburbs it covers, and send that information to New South Wales Health. New South Wales Health show the sampling results on their website. You can see on the right-hand side, the screen grab was taken from our second wave. So we're still currently experiencing quite high case numbers, and you can see there's quite a lot of detects across the Greater Sydney region of where they've sampled and they've found SARS-CoV to be present. Moving on to the next slide. So why did we set up a routine monitoring program? Initially, when we started sampling, we were only sampling at our wastewater treatment plants, and that was because it's quite easy to sample at the wastewater treatment plants. But then we had a thought and questions were raised about how does New South Wales Health use this data, and how do they use it to make meaningful decisions and meaningful public communication and target particular areas. So if you have quite a small area, so our smallest treatment plant is called Brooklyn, and that covers a population of about 700 people, that's quite easy. If you get it detected at that plant, you send out comms, you try and drive some behavior changes and get people to do clinical testing. But if you have quite a large catchment feeding into a treatment plant, that becomes a lot more tricky with how you use the data. So our largest treatment plant is Malabar, which covers over 2 million people. So when you get a detect at the Malabar treatment plant, there's a much more tricky question about how do you use that data. You can't put out comms and ask every single person in Malabar to go out to get clinically tested because it's such a large area. Malabar also covers a lot of our quarantine hotels, which means that we are expecting to get detects in that area. And so in which cases, if we're getting detects weeks after week and we attribute it to the quarantine hotels, we might be missing community transmission that is happening within the catchment, because it's being masked by the hotel quarantine positives. So in that case, we made the decision to split up a lot of our larger networks into smaller subcatchments. Each of our subcatchments covers approximately 100,000 people, and you can see an example there on the bottom of the screen. That is actually Malabar and the subcatchments that we have broken it up to. And you can see it varies quite a bit in terms of size about which areas we are covering. Moving into the next slide. So that really lets New South Wales Health make a more informed decision. So how do you select a site? As I mentioned before, the wastewater treatment plants are quite easy. We already have samplers set up at the inlets to our treatment plants. If you don't have samplers already set up, generally it's quite easy to set up sampling at a treatment plant. It's at grounds level. It's a site that you control. There's generally no particularly large access issues. You've already got people on site. Setting up sampling there, relatively easy. Whereas when you go into the network, so trying to sample from manholes, it becomes a lot more difficult. You have to really consider for us key aspects such as safety. So if you might find a particular manhole that on paper, it looks great, it covers the catchment of interest or the particular area that you're trying to sample. But then when you look a bit closer, it might be in the middle of the road. So there's a risk to your people from cars. It might be in the bush, so they might not be able to find the manhole, or on steep cliffs. We've got quite a lot of our network that is under those areas where it's quite difficult or even not possible for a lot of our people to get in there and to sample the wastewater easily. You also want to think about your sites. If people are going there for routine sampling, how can you make it safer and easier for them? So manholes are quite heavy, especially if they've been designed for to take loads from traffic. So we've actually modified our routine sites by drilling conduits into them to make it safer for our people to go to them regularly and sample every week, so that they don't have so much of a lifting hazard. You also want to consider that the flow regime within the area. So if you're using auto samplers or doing composite samples, you want to make sure that there is consistent flow coming through at the peak flow times, so that your auto sampler doesn't run dry or your passive sampler doesn't run dry. You really want to make sure that when you go out to these sites that you're sampling at whatever your peak flow is in order to capture any shed COVID particles. So you will not get a detect if the person who is infected is not shedding at the time and you don't capture that particular sample. So for us, we have what is called a morning peak, and we sample from about I think 7 to 11 a.m. to give us the highest chance of capturing the COVID particles that are being shed. Moving on to the next slide. So these are considerations you need to take into consideration. Another key aspect of having a successful program is to really work quite closely with your health department and have clear communication with them. So when we initially started the program, New South Wales Health might send us a request and they'd be like, can you sample Liverpool? And for us, there's a lot of questions raised around like, what do you mean by Liverpool? They usually mean Liverpool, the suburb, but for us, we might think, oh, Liverpool, the wastewater treatment plant, and making sure that you're communicating back and forth with your agency to really be clear about what area they're trying to sample, what it is they're trying to detect. So initially, there's often a gut reaction of there's a positive case. Let's sample where that positive case is. But no, you know that's positive. you're going to get a detect. You already know that. It's better to sample around that positive case to look for spread and that sort of thing. So for us, it was really key in making sure that the communication was clear and that New South Wales Health were able to accurately interpret the results of any samples. We used maps so that there's no misinterpretation about the area that's covered, about where the border is and what is being sampled and what is not being sampled. So we eventually started with just hand drawing on screenshots, and we've eventually moved onto a web-based mapping system where New South Wales Health are able to interact and determine their own results. On to the next slide, please. So from a utility perspective, there's really been a lot of positive publicity around the wastewater sampling program. We're being seen as good citizens and to helping the government manage the COVID-19 response, increase public literacy around sewer management. Where does your actual sewage go? Naturally, if we're able to help the health departments manage COVID, there's less disruption to our operations, there's less lockdowns, less limiting movement to people, and less risk to our people of them contracting COVID. This program has expanded quite rapidly, and we've had a lot of upskilling of our current personnel and bringing on additional personnel. And these monitoring sites are now available for us to use for future monitoring projects we might want to do, such as trade waste investigation or other infectious disease investigations. So thank you very much. That's from me.
Excellent. Thanks a lot, Tiffany. I'm just mindful of the time, so we'll keep moving along. And I'll pass over to Melody now to describe the laboratory view of wastewater surveillance. So over to you, Melody.
Hi, thanks for joining us today. I'm going to touch on how we process sample and report results in South Australia and what is the basic requirement to set up a testing lab. Next slide, please. Next slide. This slide shows an overview of the workflow, and then as mentioned earlier, Rachel mentioned earlier that the sample can come in as a liquid or in a passive sampler device. For the liquid method, 50 ml of the wastewater is processed and spiked with an internal control. We use MS2 in our lab. The blue arrow is where the MS2 is added, and a centrifuge that can process 50 ml is needed to remove all the big particles to minimize clogging on the membrane at the filtration step. The supernatant is then transferred to a clean tube and the pH adjusted to 3.5, then filtered on a negatively charged membrane. Membrane is then placed in the bead tubes and ready for extractions. For passive sampler method, a membrane is placed in the bead tubes and MS2 is added. A quicker and time-saving way to process sample in the lab, and you can do it without the big centrifuge and filtration manifold. The membrane collected is then undergoes bead beatings and RNA extractions. A smaller centrifuge is needed for the extraction step, and then the extract is analyzed using a PCR machine. Next slide, please. After the RNA extractions, there are many commercially kits available in the market. For example, we use PerkinElmer SARS-CoV-2 nucleic acid detection kits, which target the N genes and the open reading fragment 1AB genes. Some other labs in Australia use published assay methods. Example, the US CDC primers and probe, and the reagent used is often depending on what is favorable and also what can easily obtain. And ideally, more than one gene should be analyzed to be confident with the detections. And when selecting an assay, it is important to make sure the PCR machine has the channel matches the probe. And then to make sure assay works properly and reliable results are delivered or reported, it is very important to have quality control to check extraction performance by calculating the percentage recovery and also the amount of inhibitor presence. We use MS2 as our internal control and recovery control. Standard is also important to check PCR efficiency and to determine the limit of detections when you first start setting up, and always run it on a run, included in the run. We use synthesis R SARS-CoV-2 RNA control as our standards and a positive control. A no template control is also important to include to check for PCR contaminations. And lastly, we analyzed each sample extract in triplicates. Next slide, please. And now we have the data. How do we use it? I think previously Rachel has touched a little bit, but here is the flowchart created by SA Health. What we use here, and on the assumptions that MS2 internal control percentage recovery is good, as mentioned earlier, 2 genes are measured with the Perkin-Elmer kits that we use, the N genes and off operating fragment genes. When multiple genes on the left, when multiple genes in different replicates or multiple replicates are detected, then it is confirmed detections. The result can be further confirmed with sequencing data to check whether it is a real data. Yeah, it may not be needed for all samples once method is fully validated. And in the middle, when one or more genes detected in a single replicate, then it is called as a presumptive detection. The sample that undergoes secondary confirmation either by repeats replicates or reanalysis on second platform. We use Oplex, another commercial SARS-CoV-2 detection kits, and re-extractions or further sample. If the secondary confirmations came back positive, it is a confirmed detections. If it came back negative, result is an unconfirmed detection. We notify SA Health when there's a confirmed detection and a presumptive detection. On the right, it's when both genes not detected, and then it is a negative result. Next, please. Here are some laboratory requirements to set up a lab. It needs to be a PC2 or a biosafety level 2 or equivalent lab. And importantly, to have good laboratory practice and good layout to avoid contamination. Example, dedicated work areas for each step, an area for extraction, PCR setup, and post-PCR. The key things for us to success is we use experienced lab staff. If you choose to go with the liquid method, we'll need a bigger centrifuge that holds 50 ml tubes and filtration manifold. If you choose to go with passive sampler method, then you don't need to have the big centrifuge and the filtration manifold. Both methods will require a centrifuge that holds 2 ml for the RNA extractions and vortex, or a bit better for the membrane lysis step, and PCR machines. When selecting a PCR machine, it is important to check maybe you have remote access and user-friendly software and easy to export data. If you need to confirm the PCR product size, you need gel electrolysis. We use Agilent 2100 bioanalyzer. I think that's all for me. I hope I'm not too quick. Thank you.
Excellent, thanks, Melody. Yeah, sorry we rushed you through that, but that's I think there'll be a lot of questions about, and has been a lot of discussion about what's required to set up a laboratory to do this work. So we'll probably come back to that. I'll now hand over to Sudhir, and unfortunately, apologies, Sudhir, we'll ask him to go through pretty quickly through a lot of material he's got as well.
No, it's fine.
To some questions and answers, a bit of panel discussion. Okay, I'll go through.
Hi, everyone. I think the first question you want to ask yourself, why should we invest in wastewater-based epidemiology? Most of us have been trying to set up environmental systems for illicit drugs, for diseases like cholera. We see this as an opportunity. The COVID situation although it's a challenge, it's an opportunity for us to drive the wastewater-based epidemiology approach and show the usefulness to government systems. You can move to the next slide. Yeah, so as I said, we've been trying this out for a while, trying to get the system up and running, but it's only now that we're starting to get some traction. You can move to the next one. Thank you. And so the data is valuable. I don't want to go into too much details of this, but there's various population data that you can get. Next slide. Thank you. And so developing countries, there's a contrast even within the same city. You have these high-rise buildings, industrial areas, informal settlements, rural component. There's a lot of developing countries are not fully sewered. So how do you incorporate those areas into your surveillance program? Because those areas are where your most vulnerable population are. There's not much social distancing that can happen in the shared facilities. Next slide, please. And so we set up a programmatic approach. We didn't go in big first. We first said, let's get the science right. Let's see if we can detect anything. Do it as a proof of concept. Well, we then moved to pilot scale monitoring, and we brought in some partnerships. And all of this is leading into a national system. Next slide, please. And so, as I said, we got the proof right, get the science right, see which methodologies work for you. Try some standardization across the laboratories. Next slide, please. And I said, we just set up some getting the methodologies right and looking at the testing, if you can. And all of this is freely available for you guys from our website. We can send this to you. Next slide, please. Extending the science to non-sewered areas, we found passive sampling, just like the previous speakers, work really the best. There is an influence on environmental factors. Don't go looking for individual toilets in terms of a cost benefit, in terms of the business case for doing surveillance, it's not really useful. So you want to look at the population size and if it's big enough to incorporate for the non-sewered as part of your business case. And next slide, please. And said we're just getting the dashboard ready to incorporate into a national system. You know, although all the stuff is presented seamlessly, I work for a different government organization. So we work on the research part in the water field. We had to communicate with our National Institute for Communicable Diseases, and that partnership took a lot of time and a lot of effort in the communication between the various government departments to try and bring us into a national system. And that I feel, you know, getting the science part is what we do really well, is talking to each other's government departments and working together. That's the harder part. And the harder part is everyone to get that common vision on why we need a surveillance system. So next slide, please. As I said, we've been doing this. You can click on further. And this is our trends in South Africa and our monitoring within our lab cases, our clinical samples versus our wastewater plant samples. You can click on, you can go further. And how we're setting up our different type of systems and how we're doing these heat maps and hotspots. And you can move to the next slide. This is a very interesting slide because on your left, it's showing that our beta variant was quite dominant in our clinical samples. Now, clinical samples only represent 1% of the total population. What we found in our sewage, although we're finding the Delta strain took over, the gray part took over, we did find the gamma was occurring in a large percentage, 62%. But it doesn't show, what it's also highlighting is that it's not showing us so much in clinical samples. So maybe the symptoms are not as predominant as in Delta strain. So this is the importance of doing this wastewater surveillance. Next slide, please. And this is my last slide. And I think there's opportunities to learn from cold storage supply. You know, when we first started doing this, do we have the laboratory set up? Do we have the capacity? Do we have enough kits? How do we bring rural areas into the fore? You know, I've been reading a lot of stuff on Mauritius and Maldives and how they brought in these new PCR machines. They trained up staff, and the hotels were running the cold storage to keep the samples. So there's a lot of lessons and partnerships you could set up with your hotels, with those type of private sector individuals to let this to set up the actual supply chain for this PCR testing and involvement. So that's the end. Thank you.
Excellent. Thanks, Adir. And sorry we rushed you through that a little bit. There's a lot of great information there and a lot of great learnings that people, I'm sure, would like to explore. And we'll talk to you about the references to your material and put those on the ADB website after the webinar today so people can access that material. So what I'll do now is I'll hand over to Marlene, who will help facilitate some discussion there. I'm sure people have got a lot of questions based on the great presentations that we've had. So Marlene, are you with us?
Thanks, and thanks to our presenters, to Rachel, Melody, Tiffany and Sadir for your really interesting presentations. So please, everybody, continue to put your questions in the chat and we'll read them out as they come through. So there was a very good comment from Monica, who was curious to hear from our Pacific Island colleagues as to what use case, if any, you see for wastewater testing in your settings. So I'm inviting anybody to please raise your hand if you would like to speak to that. Or please continue to respond within the comments as well. I think we have a raised hand from Jingming.
Yeah, thank you very much. I'm Jingming from ADB. That are really, they are all very great presentations. You know, that's an eye-opening thing because anyway, COVID is a new thing, and how to really check from wastewater is another new thing. I have several questions for different presenters. The first one, just about this sampling. I just wonder how sensitive this sampling can be, and then will the wastewater, the standard wastewater treatment, be able to remove all the virus? So is the effluent from the wastewater treatment safe enough to be discharged into the natural water bodies? And also, when we take samples, of course, we cannot analyze the sample very soon. Yeah, it may have to be kept for some time. So how long we can keep the sample, and then it is still valid for testing the COVID. So is there any analysis to show how long this COVID virus can live in this wastewater? So, because of course, ADB, we really care about this slum area people, low income people. So they live in very poor areas. Maybe they would contact their wastewater discharged randomly every day. And how dangerous it would be. So sorry, several questions. Okay, maybe I would leave to you, and then next round I would ask some further. Thank you.
Thank you, Jingming. Please feel free to also put some of your questions in the chat if they're not getting answered, and we can come to them as well. Rachel, you might be a good person to speak to these.
Sure. That was quite a number of questions, but please remind me if there's any that I've forgotten in terms of the safety and where to take samples. Generally the influence of a waste treatment plant before treatment, because the virus, I guess, degrades quite quickly, and any treatment, I guess, makes it more difficult to be able to detect the virus. So, and I think the question around how safe is it to handle the wastewater samples prior to treatment, I guess as long as you follow the advice, as long as you follow the OH&S and the WASH guidance around hygiene and wearing the appropriate PPE, the risk is minimal if you do follow those procedures. And I think Water RA did put together a fact sheet on water and sanitation and the handling of wastewater samples. So sure Marlene and Dan can probably circulate that. And then in terms of, sorry, I've forgotten some of the questions. The sensitivity of the sampling, we've found certainly the test method that has been developed and the test method that we're using is very sensitive, and we're able to detect very low levels of virus. For example, in a particular catchment, we can detect a single case in catchments of greater than 100,000 population, and in smaller settings, we can certainly detect a single case as well. So I guess that's from that perspective. But Melody, you can probably talk to the limit of detection of the various techniques, but also it is worth mentioning that the specificity of the test method is also highly specific just for the virus as well. So that's been well validated. And then Marlene, do you mind reminding me of any other questions that I haven't answered?
I think we could invite Melody to speak to the limits of detection as well.
The limit of detections, I think, is depending on what kits you do and what primers you use and what reagents you use. So you have to firstly, when you're starting to set up an assay over there, you have to understand how your assay performance. I think is assay to assay. So for us, I would say our detections is 10 copies per reactions is our limit of detections. Then any above that we normally will do a further conference of that sample. And also I think there's a question about the storage. I think for passive sample, I think we have retest sample that have been stored for a week and they're still performing the same, maybe slightly less sensitive in detections, but for liquid sample, as long as they are stored at 4 degrees, they normally are quite stable, same as the passive.
Thanks, Melody. Sudhir, are you able to hear us? I'm not sure if you caught some of the questions, but it would be interesting to get a South African perspective as well.
Yeah, I didn't catch the majority of the questions, Marlene. My line dropped a bit, but I think for me, the important aspect of doing a lot of this, what is the purpose of having this? And I think in South Africa, it's for us, or we found it as an opportunity to include wastewater-based epidemiology as part of a national program. That's where you want to get. So the methods, the science, we are good at that. Scientists are good, molecular biologists are good at that. They get to that. It's how you integrate this into a national system to keep it going for a long time. That's the important part. So that's just my little mini statement.
Thanks, Sudhir. Perhaps another question for Melody as well, which came through from Kirti. Can the vortex be used for separation instead of a bead beater?
We do use vortex. It just need to have higher speed. The one that the kits manufacturers suggested to use are the Vortex Genie 2, that you which is just can it just vortex at a higher speed than a normal vortex. So if you want to change the speed of the vortex that you're going to use, you just need to test the efficiency of how well it lies as well. Like you just need to put in more effort instead of following the manufacturer's suggestions.
Thank you.
Thank you. And another question from Jingyin. Will the standard wastewater treatment plant remove the virus and discharge the effluent to water bodies safely?
I might take that one. I'm not sure what you mean by a standard wastewater treatment plant. I'm not sure what the standard is across the Pacific, but what we have found is that the virus is very fragile within wastewater. So even within our network, because we have a large amount of, say, detergents or soap or cleaning products being put down our network, we found the virus is deactivated very quickly within the network. If your wastewater treatment plant has some kind of tertiary treatment, it will kill the virus or deactivate it by removing the membrane that's on the outside, and it won't be able to infect people. So yes, so if you have that kind of treatment, yes, you can definitely discharge that effluent to a water body, and there will be a very low risk of anyone contracting COVID. I don't believe there have been any confirmed cases of someone contracting COVID from wastewater. It is considered a relatively low risk to the other dangers that you can have working with raw sewage. So as long as you follow your normal OH&S procedures, you should be good.
Thanks, Tiffany. Moises, I see a comment here in the chat. Passive sampling and composite sampling, accuracy of the results obtained from a duplicate sample. I think perhaps it is, I'm not sure if it's framed as a question, but can one of our panelists perhaps speak to that? Or Moses, if you'd like to clarify a little bit what you'd like to find out. Thank you.
Thank you, Malin.
Yes.
I was just would like to know if the sample obtained from a passive sampler and also the sample obtained from a composite sampling, the comparison of the outcome of a duplicate sample, it will be 80 into 80, or there'll be a little variance in terms of the data. Thank you.
Rachel, would you like to speak to that?
Yeah, I can talk to this a little bit. So I guess our collaborator, Dave McCarthy, who designed the passive samplers, has done a body of work comparing passive samples against composite samples and grab samples. And he certainly found that when there's a detection in the wastewater samples, then there's usually a detection in the passive samples. So there's good correlation. But he also found that the passive samplers were certainly more sensitive than the grab sampling, but as good as the composite samples. So I think in terms of, gold standard, composite samples used to be the gold standard, but I think there's certainly increasing use of passive samplers because of the ease of deployment, and also it's much cheaper paying $20 for a passive sampler than it is paying $10,000 for a composite sampler, and it's I guess can be applied in a range of different settings within the network or in smaller facilities. So I think that's, yeah, I guess there's also a paper that Dave McCarthy's published around passive samplers that has done some of that comparative work. So I think Marlene can probably share the link for that paper as well, which has some additional background information.
Dan, if you wouldn't mind copying and pasting that into the chat, that would be wonderful. The question as well from Maria. Let me just get it here. Chat's moved along and I've lost the question now. How long has it taken to gear up for a sewage surveillance program in a new jurisdiction? So, for example, in our different states in Australia, how long would you say it would take to get the program up and running? And Maria also says we should involve health department, utilities, labs in this process. Anyone else? Tiffany, would you like to speak to the New South Wales context?
Yep. So I think it will depend on what you have available. So for example, we've been able to bring regional partners on very quickly, often in under a week, where we might just send them out a package and they could do a sample and send it back to us. If you need to get a lab up and running off the ground, I imagine that will take a lot longer. Like we started with having lab capacity and then moved into bringing wastewater treatment samples and regional partners on quite quickly. So I can't speak to how long it'll take to get a lab up and running, as that will depend on how many experienced staff you have and the methodologies you are using. But in terms of getting sampling sites or getting samples to start a program, I think you can do that quite quickly.
Thanks, Tiffany. A question for Sudhir. You mentioned that there were different types of unsewered connections. Could you please maybe elaborate on that a little bit?
Yeah, so most developing countries have a mix of sewered and non-sewered approaches. We felt that we needed to include the non-sewered aspects because it is more difficult. Whereas sewer, everything will come down into a pipe. I'm not saying it's easy, but everything is collected in a pipe, and you know a sampling protocol for that. You can sample at the head of work, so you can sample your sludge, or you sample, you have a very known sampling point, sampling boundary. With a non-sewered, it's quite open. So you might have open defecation, you might have someone with a pit latrine, or you might have someone with a septic tank, all within the same area. What we want to do is include the non-sewered people as part of a citywide surveillance, mostly because they are the most vulnerable. They have higher housing densities. They share facilities, even ablution facilities. So the opportunities for rapid COVID spread or any other disease, and we'll see this in cholera, is quite quick in those areas. They also don't have the access to all the resources for great hospital care. And so we included the non-sewered aspects. We use the passive sampler. I see people have been writing on the chat on passive sampling. We found this is easier. In terms of a business case for wastewater-based surveillance, we find don't go individual households, or unless you want to look at a whole apartment block, or in terms of flights coming in or those type of things, that's okay. But in terms of a national program or to look at disease outbreaks, in terms of clinical samples, you have to build a business case for that. And so I would say anything above 100 or 200 households or high density informal areas. But a passive sampling for us, just like the Australian teams did, worked the best for us.
Insights here. Monica, you've got your hand up.
Yeah, thanks, Marlene, and hello, everyone. My name is Monica Nolan. I work with Rachel in the Victorian Department of Health. Just wanted to comment on Maria's question about how long does it take to gear up and who should be involved. And I think, as Sudhir was mentioning before, when we talk about the health department being involved, the health department also has different components. And I think it's really critical that the people that are involved in thinking through what would we use this information for a public health response and what is relevant. In the short term, medium term, long term, the context can change quite quickly. The people within the public health department that are involved in those decisions are really critical to involve. And I think the other key group of people that need to be involved are the communication specialists. I think, as Rachel mentioned, there's a whole lot of work in setting up the sampling, the lab, the test results. But if we have those results and there's no action in terms of we've got a wastewater detection in this population area and there's a change in testing uptake and in testing delivery services, we've missed the boat. So I think having the people involved in thinking about if we got a detection in this area, what would be the communications that would be compelling, that would be reaching the right people in the right languages, in the right media, they're also critical groups to involve. And I think that's a combination of probably some expertise within health departments, but also some community engagement and involving the key people that are also contributing from their community perspectives as well.
Thanks for that, Monica. Melody, I was wondering if you could comment on the way that your lab trained up a lab in another state with PathWest, and also now your experience with Vietnam and working with the Mekong countries.
I think Paul have my colleague Paul has been heavily involved and have given a few presentation to Mekong and tell them the how do they sample, how do they start from sampling the sample, and then how are they going to, what do they require to set a lab over there. And we just and we send some passive sampler to them, and then for them to first trial and see how they go with them. And if they're happy with that, then they can think how are they going to do to establish a lab there. And how for Western Australia, we basically have a few discussions or meeting with them, and then like try to see how what they have been doing in over the lab there, and then try to help them to analyze or feedback on what can go wrongs in their system, in their processing method, and then try to help them establish the matter over there by just communications oftenly.
And you mentioned earlier, Melody, that having experienced staff is quite important for this work. What do you think are some of the key skills that are important for undertaking the analysis?
Understand how the whole assay works and where the potential problem can come from. Like example, you have to know the inhibitions is very important for this case, because you don't want to underestimate the or underestimate the number of copy of genes present in the samples. So there's some word that you need to know. What you need to look for when you have a result, you need to check for inhibitions and the percentage recovery, and what the data tell you. Is that a real data when you have a positive, and how confident you can be. Yep.
Thanks,
I guess that's it. Yep.
I might call on Dan as well to perhaps share some of our experiences with rolling out a program in Vietnam and working with in-country partners there.
Yes, I think the main experience, the main lesson we found is that we need to tailor the whole approach to the context. And rather than have a method that we supply, we work with the health agency, the water and sanitation agency, the laboratory partners, find out what their capability and capacity is, and then look at the best solution for the team, and then work with them as mentors, as partners over a period of some months. It takes at least some months to get a program working. And so it's really a partnership of utilities, health departments, and laboratories working together to share the methods and help interpret results and help design the program. And Sudhir will probably have similar view. Every context is different. For example, they may not have enough staff in one lab, but they may have staff in another lab that can fill in the gap. I know that Tiffany will give examples from Sydney Water where they've had to recruit new staff. Department of Health in Victoria have had to recruit new staff to fill those roles. That takes some time to do. And so it's a tailored process for each site and situation.
Thanks, Dan. Another question from Moses in Fiji, which probably for Melody, which RT-PCR brand supplier machine is recommended for us in Fiji as beginners in terms of cost and also being user-friendly and providing results readily to be used by authorities?
We use a light cyclone ID6. I think the price has gone down. I think it is roughly 350,000. Is that right? Yep. For per machine now, it used to be a bit more expensive, and that is what we use in the lab. There's other commercially available Pcr machine out in the market, but I just need to see what is your budget and how much money you have, and then what you can afford and what channels do you want and how well. It's all depending on, and also a bit. And for the RT-PCR reagent, we use the commercial available kits, which is a PerkinElmer kits. It is roughly $520 for $50 for 50 reactions, and so per reaction is roughly $10. So it depending on your budget and what costs beneficial to you to use, whether you want to publish assay methods by using your own reagents that is in-house is cheaper to run, but first thing you just need to make sure they works properly over there. Sorry, I'm not very good at answering questions.
No, it's very good, Melody. Thank you. And Sudhir, would you say that you've had a similar experience in South Africa in terms of the lab setup?
South Africa is quite well set up for laboratory. Where we had challenges was more on the standardization of the approach and how you present the data. I think that's a different aspect. But in a lot of other African countries, having worked in sub-Saharan Africa, the trouble with trying to find the right equipment, there's a lot of importation taxes. We find that sometimes equipment, South Africa is much cheaper than some of these other more poorer countries. Just trying to get equipment in is quite a lengthy process, getting kits and things. So my suggestion is, I'm reading the chat. Try and choose equipment that's flexibility, so you can add more stuff and do multiple analysis. So a lot of countries, developing countries, especially for similar type of research programs are dependent on grants. So it's very important that you have this flexibility machine that has flexibility in approach to detect different things or use different approaches. That's my suggestion.
Thanks, Sudhir. And Dan's made a good comment here as well. He said, keep in mind that the investment in wastewater surveillance can have other benefits for other clinical and environmental monitoring work beyond SARS-CoV-2. So a question from Maria: what are the considerations for unsewered areas and also remote Pacific islands that are different to major centres with sewered systems? Sudhir, you might be best placed for this.
Yeah, for unsewered areas, why you have to first ask your the question, why are we doing the surveillance? You want to see hotspots, and so you have to drop a business case to say, is it comparable to clinical testing first, and can you assist in hotspot flare-ups? That's the first question. So if you're only going to do 3 houses that are non-sewered, it's obviously going to be cheaper to do clinical samples that way. But if you have a very high density area with many, then you will looking at maybe we should do a surveillance. We found COVID on door handles and in communal facilities. We found it everywhere. That's not the answer. The answer is, how do we develop is this an appropriate business case for us to developing as part of a national system? So even in the future, if you think of cholera outbreaks, we've had cholera outbreaks in 2000, and every time we have a major, there's no, we're not an island basically, so we share borders with other people, with other countries, and so if a cholera outbreak happens in another country, it can come into South Africa, and so those type of things, it's nice to have a quick response. That's the considerations you need. You need to look at the business case first. The second question was septic tanks, and you detect it. I'm sure you'll detect it, but again, look at your business case, why you want to do this. For us, it's a good opportunity. We've been pushing for many years to bring up wastewater-based epidemiology as a national system. The COVID response has shown the usefulness of doing this. And so for your own country programs, it's showing you the usefulness of investing, even if you're looking at equipment, getting the kits, those type of things. That's where the benefit is. So I hope I answered those 2 questions.
Thanks. Jingmin, although we don't very often have septic systems in Australia, one of our partners in South Australia has actually sampled from a portable toilet or portable toilets that are installed in festival areas. So it was an appropriate methodology for that context. And I think all of our Australian partners, particularly in Victoria with Rachel, they have various targeted testing regimes as well, looking at specific sites. So I think our Pacific partners would probably be quite familiar that it's also possible to test for polio and typhoid, which has historically been done in the Pacific. So I guess this is a small step that we've got here. There's a couple of links from Dan in the chat.
I just put some links in, just some deliberately choosing links from before SARS-CoV-2 to show that for typhoid and polio, a lot of environmental surveillance took place, and they used to use in unsewered areas the stormwater, river water, channel water, and other types of water. So there's some useful experience that can be used to learn from.
Perhaps a question for everyone. I mean, once the processes are in place, how can they be used for other surveillance, for other things apart from COVID? How adaptable are the methods? Dan, if you would like to speak to this as well. Oh, sorry, Rachel, you go.
So there's a couple of questions in the chat about application for unsewered areas or septic tanks. We have had some experience in sampling from septic tanks, the effluent from septic tanks, and we simply just dip the passive samplers in with that flow as the septic tanks are getting emptied. So there's some mixing, but yeah, we've been able to sample from those settings as well.
I think, yes, not very efficient for household scale, because you might as well test the people in the household. I think Sudhir was discussing this previously, but if you have a festival or event or a religious festival or sports event, the on-site sanitation system can be tested. I think, Melody, you've done some testing, haven't you, at some on-site sanitation systems at large events with large population, and also the sludge tanks from boats and aircraft can be tested, and mining sites, industrial sites. So sometimes with many people using one system, the single system can then be a useful test site.
It might be applicable in areas where they might have communal septic tanks, for example.
I've got a question from Kiribati as well. Is there any other tools that's applicable in the community level? Templates or tools, can you please share the presentations so that we can go through them and come up with some ideas from your experiences for our context? Will the presentation be shared as well, Dean?
Yes, it will be, yep. And I've got downloading those documents Dan's linked to, so I'll put those up, as well as Sudhir's documents as well. So we'll put all those on the ADB website.
And Sudhir, you've also commented that as well.
Yeah, it's just for surveillance, you know, we've seen people looking, as Dan mentioned, looking at planes as they come in to see if people have COVID, university residences, because they usually a lot of young people hanging around together, you know, high density also. So those are different types of surveillance types of options you have. So even a hotel within your areas, especially if you have you rely on a lot of hospitality industry. You know, you can look at where people are staying when they come in, and so yeah.
Can you take samples from ocean water, salt water? Some of the smaller countries, they might have discharge not via streams, but it pretty quickly gets to the ocean in lagoons, etc.
Got a question from Xing Min. I didn't quite follow the question.
Yeah, maybe can I just explain a little bit, because I think this really triggers a lot of consideration from our side. Melody mentioned how difficult it was to take samples from these sewer manholes. And then I just wonder if we really need to monitor the sewerage and consider this wastewater surveillance. Should we really design the sampling system in the original sewer system design? So we put some sample points in the whole wastewater system, and then when it's needed, we can just use this point to take their samples. So this also corresponds to what Sadir said that we should look beyond the COVID-19 because, of course, we cannot guarantee in the future there will not such a thing. Yeah. So then in this case, maybe we also need a system. It's like a water supply DMA, district metering areas. And here, maybe we need a district monitoring areas for sewerage. And then the DMA for water supply, you would work all the time to monitor the non-revenue water. But here, maybe the DMA for sewerage only works when the situation needs, when this pandemic or some disease we need to monitor. So I want to listen to your comments because you are all top experts on that. How often you would see this situation happen, because for everything we need to consider the cost and benefit. Yeah, if we do design this sampling thing or consideration of the district monitoring in the sewer system, how much cost we need to put, and how much benefit we can get in case of the pandemic or other disease. For your comments, thank you.
Thank you. Tiffany, you've done a fair bit of modelling on the networks. Perhaps you'd like to talk about the infrastructure design?
So work found that the infrastructure design of a sewage network will often be most heavily influenced by your topography, in which case, especially if you're doing gravity sewers, you might not have a lot of choice in terms of how you design your sewer system, in terms of where it runs and that sort of thing. We haven't found it overly difficult to sample within the network in terms of manholes, if you're able to access them. So perhaps if you're going to think about any design changes, you would think about how your people would be able to access manholes and if it's safe for them to access those particular areas. And then the other issue is depth. You have a depth issue if you're using auto samplers to do a composite sample, because they can only pull up so high. For us, we've found 7 or 8 meters, although we've been able to come up with other solutions to get about 15 meters. If you're getting much deeper than that, you really want to look into passive samplers, because for them, the depth isn't as much of a restriction as you just tie it on a string and lower it down as far as it goes. Has that answered your question? Any other?
Yeah, Pat, I just wonder if it's necessary for us to consider this sampling from the very beginning, or based on your experience, what you mentioned is it's not so difficult to do the sampling, so no need to put any consideration in advance, and when it's needed, we can just do the sampling as required. Is that correct?
That's generally our experience. We're also working with quite an old sewage system. It's 130 years old, I believe, in some places. If you're designing it from scratch, certainly keeping in mind the benefits you can get from monitoring the network in terms of not just infectious diseases, but also how you manage your network and being able to look after the sewer, I don't think there's any harm. It's certainly only a benefit you're going to get from considering those sorts of things. But if you're working with existing sewers, or perhaps you're constrained a lot by topography, then I don't think you'll be held back significantly from putting in place a monitoring program.
Thank you. Thank you. Very clear.
I'm just mindful of the time there, Marlene. We might, I think there's a lot of interest in this topic, and we could probably talk all afternoon. So. But unfortunately, we might need to wrap, let everyone get on with their busy days. So we've probably got time. Are there any final questions there?
Maybe Melody could talk to the NMI study for the positive controls and negative controls that you use in the lab very quickly. Question from Kirti about that.
Yeah.
Yep. On the MMI trial, a set of samples were received from were sent from which lab, MMI, and then we receive it. It is a blind test, that blinded test trial that we were doing, and the standards, there's 5 sets of standards, and with the concentrations were given, and then we tested them we use them, and also a spike control is sent together as well, and so we spike them to the samples, and then we extract the sample using our method and process the data. And there's an Excel spreadsheet that's is already pre-created, and then once you enter your data is entered, you cannot change anything. So to make it more confidential, maybe, and we found that our lab is quite the method that we use in-house here is quite good compared to others lab, and it's the reproducible and quite reproducible too. And I'm not sure what what else do you want me to talk about then?
I think that probably answers the question. Yeah, that's good. Yeah.
Yeah, thank you.
Yeah, okay. Well, I might have to unfortunately call a halt to it. I know that people probably got burning questions, but look, certainly as with our other webinars, we're not done just as we finish today. Please stay in touch with us if you've got questions. We can, yes, talk to our presenters and panelists and see if we can provide some assistance. I'll just close up and just thank again our panelists and presenters for giving up so much of their valuable time to help pull the presentations together and be here today. So thanks a lot.
Can we also, get people to turn on their videos? We might do a quick screenshot of everybody here, if that's okay. Thank you very much. I see all your videos coming on. Yeah, once again, we'd like to thank the panelists. It's been really useful for you to share your information with us and your experience. And, you know, I hope that Dean or myself or all of the national consultants here are familiar faces to you all, and you can feel free to reach out to us at any time. These presentations and this recording will be up on our website as well, so you can come back and listen to them or read them, and always reach out to us because, you know, we can offer support under the TA as well. Thank you very much.
You got your family photo, Maria?
Yes, I'm just trying to make sure I have everybody. There's lots of pages, but I will have you all in one more second. Thank you.
Okay. Well, thanks for your attendance today, everybody. It's been a fascinating webinar. We look forward to the next one.
Well, thanks, Dean. Bye,
Okay.
everyone.
Thanks, everyone. Have a good day.
Thank you for arranging that. Very good. Thank you.
Thank you.
Thank you.
Thank you, everyone. Bye.
Thank you. Thank you.